our evening's seminar, and it is on GERD and hiatal hernias. Is it time for surgery? I am a gastroenterologist, and I'm the director of a center called the Digest Center, which stands for Dedicated Integrated Gastroesophageal Treatment, and that is at Weill Cornell Medicine in New York City. And this evening, it is my absolute pleasure to have a panel of absolute experts who take care of patients day in and day out with reflux disease and with hiatal hernias. And hiatal hernias and reflux disease are an incredibly common condition that patients deal with. And this evening, we are going to have an opportunity to talk about the patient experience, what reflux disease is, and the relationship to hiatal hernias, and whether or not hiatal hernias should be repaired. So, with me this evening is Dr. Philip Katz. He is a gastroenterologist, and he is the director of the Functional Motility Laboratories at Weill Cornell, and he is an expert in reflux disease. And also with him is Dr. Kartik Sampath. He is also a gastroenterologist, an interventional endoscopist, which means that he does a lot of very fancy things with an endoscope to try to repair things like hiatal hernias. And he too also takes care of these patients on a daily basis. And lastly, we have Dr. Rasa Zarnagar, who is a surgeon, and he is the director of robotic surgery at Weill Cornell, and he will be joining us as a surgeon this evening in our webinar as well. With that being said, I'm going to just put up this disclaimer.
Jeez.
And that is, you can read that, but that just shows that the opinions expressed in this podcast are those of the speakers and do not represent the perspectives of Weill Cornell Medicine as an institution at large. Perfect. So, what are we going to be talking about this evening? The first is an understanding of what is a hiatal hernia. What is that? We're going to explain that in many different ways. We're going to explain that from the patient perspective, what it looks like in endoscopy, and also from the surgeon's perspective as well. We're going to then go on to understanding how common are they? Are there different types of hiatal hernias? And does that actually impact whether or not we actually need to repair them? We're then going to look at how do we evaluate hiatal hernias? What does it take to understand what type of a hiatal hernia do we have, and how do we then actually manage them? So that's going to bring us on to the last part, which we're going to spend a lot of time on, which is an understanding of how are they fixed. So with that being said, I'm going to present to you our patient. This is a patient with heartburn. He's 65 years old, and he's had 10 years of really frequent heartburn symptoms. It happens at least 3 times a week, and sometimes this actually even wakens him from sleep. Because of the frequency of the symptoms, he takes over-the-counter pantoprazole, which is also known as a proton pump inhibitor, but he takes this, as needed. And over the last year, he started to also notice regurgitation, which for him is he's experiencing a sensation that liquid is actually coming up from his abdominal cavity into his chest. And this is especially happening to him when he's lying down, especially at night when he's going to bed. Now, doesn't really have nausea or vomiting or any issues with swallowing. And beyond these symptoms, he's really a healthy individual, but his primary care provider on his regular laboratory studies has actually noticed that his iron is a little bit lower than normal. So, Dr. Katz, when you, as a gastroenterologist, when you see someone that comes to your office with these types of symptoms, what do you start to think about this when you start to hear these symptoms? Does this make you think that this is someone that you need to do more of? Where would you start to sort of work with this patient?
Mhm. So the bullet points here are actually quite instructive. Felice, the number of years of heartburn is really quite frequent. 10 years puts him in a category that would almost mandate thinking about doing a workup. In the past, when we tried to distinguish between intermittent or frequent heartburn and GERD, the 3 times a week heartburn, occasionally waking him from sleep, is a little bit more important than occasional heartburn, and I would be concerned that this was GERD. I'd remind our patients that over-the-counter pantoprazole is fine to use, but the label says to take it every day for 14 days because proton pump inhibitors are much less effective when they're taken as needed. So a daily dose is important. Regurgitation is a symptom that Dr. Zarniger and Sampath will probably discuss in a little bit more detail when it comes to therapy. But the subtlety here is a low iron, if that's associated with also a low hemoglobin and anemia, might suggest that there is a little bit more of a complicated disease.
Okay, so this sort of compilation of symptoms is making you think that this is not just simple heartburn, and maybe he needs to be seen by a physician at this point in time.
I would, yes,
Okay, great. Thank you.
and
Okay,
actually a specialist.
specialist who deals with it. I agree with you on that. So, we're learning a little bit more about him. He's really done a lot to try to deal with his symptoms. He cut out alcohol, coffee, citric products, pasta sauce, but this didn't seem to help his symptoms. And he also, had read that eating late at night, especially, close to bedtime, was also something that wasn't good for reflux disease. So he's now not eating 2 hours before going to bed. He used to be overweight, but a lot of the dietary changes that he's done, specifically because of all these symptoms, brought down his weight to what we consider a healthy range. That also didn't really seem to make that much of a difference. And now he's started to take the pantoprazole on a daily basis, 30 minutes before breakfast. I think Dr. Katz, as you're alluding to, it's really important to make sure that you're very compliant with these medications, and these medications may require some special things. So, but his symptoms, in spite of that, didn't seem to make a difference. And he's having symptoms later in the day and at night. So he goes to his gastroenterologist for evaluation, who schedules him for an endoscopy because of this change in symptoms. So, first of all, Dr. Sampath, when someone now comes to you with all these things, you know, what are you thinking is going on now based upon all of this? It sounds like he's really done a lot to try to help himself. So, what does this make you think is happening?
Yeah, so first I just commend the patient on taking such a individualistic role in empowering his own healthcare by being proactive. And it sounds like there's been multiple things that have been done on the basic levels: lifestyle, diet, medications. The first thing I want to just double check is the compliance part of everything. Assuming that's all in place, then the suggestion here is there's some other component contributing to further symptoms. That could be, in unique situations, hypersecretion of acid, but more likely there's some disruption of the anti-reflux barrier to an extent that could be contributing to regurgitation-based symptoms as what's being described. And based off of those symptoms, he may need more help. And that could be in a lot of different ways. First, seeing an expert, ensuring these basic things are optimized to the nth degree. However, there may be a need to do further interventions, including augmentation of the anti-reflux barrier.
So basically, what you're saying to me is like listening to this and all the things that this patient has done, you're thinking that there might be something about his inside, about his esophagus, his stomach, that needs something done to it potentially, because just in spite of all these things that he's doing, it's not enough.
Correct.
Okay, so he was referred to a gastroenterologist, and as we mentioned, an endoscopy was ordered. So, Dr. Katz, could you walk us through what we're seeing here on the left picture and on the right picture? Kind of what is this and what does a gastroenterologist like? Why is a gastroenterologist actually even doing an endoscopy when somebody has reflux disease?
Doing an endoscopy for multiple reasons. The first is to try to make an accurate diagnosis. Look for damage in the lining of the esophagus or the mucosa for the finding of what we would call erosions. There might be one or two of these here, but we'll leave that for later. We're looking for other features related to reflux. In this case, we'll point out a hiatal hernia in both parts of the slide. And we're looking for other features that may impact outcome. But in general, we're looking for mucosal damage or damage to the lining, the presence or absence of a hernia, and the integrity of the anti-reflux barrier, or what is often referred to as the valve.
Okay.
So
Now,
on the
I mean,
left, I'm sorry, go ahead.
now, and I'm assuming also, I mean, some people obviously, not that it's common, but I'm sure some people worry that there could be cancer or something, right?
That is correct. And at some point in time, as we've had other webinars, we would be screening the patient for the presence of a precancerous lesion like Barrett's esophagus. In this case, if we found that, we would deal with it. But the primary purpose of this endoscopy is to make an accurate diagnosis.
Okay, so the reason why we're looking is because there are really a lot of things to find, and it can help us much better understand who the patient is. So,
Right. So, go ahead.
what am I seeing here on this left slide? What is that?
So as I'm looking at this slide, on the left is what we would call a forward view,
Mm-hmm.
moving the endoscope from the mouth down into the stomach region and into the abdomen. You see some prominent folds here with a narrowing of the area down towards where you're putting a circle. The circle is where the diaphragmatic pinch is. That is truly where we're entering the abdomen. Above that are what we call gastric folds, and those gastric folds are widening out into where the actual esophagus would end, and the gastric folds being the stomach beginning, and that is a hiatal hernia.
Okay.
Um, it's hard to estimate the accurate size, but it's certainly not trivial. And on the right, what we see is what we call a retroflex view. The black area there with the little white line that you're going to point out is actually the scope looking back on itself. This is a way we assess part of the integrity of the anti-reflux barrier uh, to determine a little bit more than GERD, no GERD. So what one sees here is an opening. There's a space between the scope and the end of the esophagus. There's a little whiteness there that is the gastroesophageal junction or the end of the esophagus. And next to it is the stomach. You can actually see back into the esophagus. Normally, we would put a little bit of carbon dioxide via the scope to inflate or to put a little stress on the sphincter to see if it would pop. And this is a classic appearance of a hiatal hernia. Both of these photos would indicate that that was the case.
Okay. So you do the upper endoscopy and you're looking to see is there damage, making sure there's no cancer, no precancerous conditions, and you see what looks to you like a hiatal hernia.
Yeah, I
So,
might also comment very briefly, Dr. Schnall, just for the audience. There are tiny little erosions in the folds on the left, and this would potentially tell us why the patient was anemic.
yeah, now, and I think that's a very important thing. So, are they also, I mean, is that also blood that you were seeing in there?
It might be.
So,
I wouldn't put it past in retroflex view to see just a tiny little bit of oozing or an erosion horizontal to the opening. Uh,
okay, so does that explain some of what the symptoms were for the patient?
You could go to medical school on this photo for sure. I
But
mean
I mean the anemia because if you're telling me there are erosions here and there's
this
blood,
this would give me a strong likelihood that if the patient was anemic, responding is responsible for his low iron, that this would be a very, very strong reason for that to occur.
okay. So a lot of information from just really this one simple test, basically, that you were able to glean from the upper endoscopy.
Correct.
Okay. Um, So the other thing that I think is important is just for us to even just get a sense to compare, because we saw now the hiatal hernia, which was a picture that you just pointed out for us that's on the right. And Dr. Katz, could you just describe for the audience the difference here between this is a different patient, obviously, but on the left is a normal view. So could you just sort of describe what's the difference for the patients so they understand the hiatal hernia?
Yeah, so the area on the left, or the photo on the left, looks uh, normal for multiple reasons. Number one, the endoscope is tightly wrapped by what you see in a circle that you're pointing out. This would indicate that uh, the valve area is normal, that the gastroesophageal junction does not easily pop open with distension. This is a normal EG junction or a normal valve. Both Dr. Sampath and Dr. Zarniger would take this into consideration in determining what intervention we might do if we got to that point. Two different ones, a wide open, what we call a Hill 4 or an AFS 4 on the right, and on the left, a Hill 1, AFS 1 normal valve.
Okay, so how wide this is around this scope is really an important thing to you when you're seeing it.
It is for me. Dr. Zarniger will comment at a time you ask him to.
Okay. So, I mean, actually, it's a perfect time right now. Just for a second, so Dr. Zarniger, when you're doing an endoscopy or when the gastroenterologist is talking to you about someone who has reflux disease, regurgitation, things like that, and you see the difference between, let's say, what this normal valve looks like and this valve, is that something that's sort of making you think I might need to repair this hiatal hernia?
Yeah, thanks, Elise, for setting this all up and the audience for being here. I agree. I think when you see a normal valve, you're less concerned about reflux. You can still have reflux with a normal valve, which I think, Dr. Cass will talk about testing. But if you do have a hiatal hernia and all the other signs of reflux with testing, yeah, I think those are the ones that really require some type of surgical intervention because the hernia in itself, or hiatal hernia, is just a hole in the diaphragm, sort of similar to when you have an inguinal hernia. So yeah, the one on the right clearly is definitely abnormal and may warrant further intervention depending on testing.
Okay, excellent. Okay, so I think we have a really good sense of what a hiatal hernia is. Now, let's just talk about some of the things that we're going to talk about this evening. So we're going to talk about how common are they, what are the different types, how do we evaluate them, and how are they fixed. So Dr. Zorniger, you just started speaking with us, about this, and obviously, as a surgeon, you have your hands or your scopes inside the abdomen, the chest of these patients. Could you explain to us really what is a hiatal hernia? It is such a common thing for people to talk about, hiatal hernias. What is happening here? And these are just two sort of cartoons that depict it. But can you tell the audience what is it?
Yeah, I mean, I think a hernia, like very other hernias that people may have noticed, like a belly button hernia or an inguinal hernia or a groin hernia, the hiatal hernias are basically a hole in the diaphragm instead. So it's a lot of it is considered to be related to some genetics where some people have a weaker diaphragm. And so the muscle is weaker and then somehow that starts breaking apart. So sometimes families will notice that their, uh, parents or grandparents have had hiatal hernias. So there's a tendency for a tract within the family and so on and so forth. The base is a hole in the diaphragm. And what we do to fix the hole is just to try and close it and bring the stomach to where it needs to be. And when does the whole things pop through? And in this case, usually the stomach, but other organs can also go through, including the colon, the small bowel, and other organs. So definitely something that's worth investigating if you do see one.
Wow. So, I mean, that's incredible. So it could be the stomach could go through, but it could actually pull other organs up. And we're assuming that it has to do with like how big it is. Could a hiatal hernia become an emergency if those things are happening?
Yeah, so in rare scenarios, a lot of people have hiatal hernias, but in rare scenarios, you can have certain types of hernias that can twist in the chest, or other organs can get stuck in the chest and require emergent surgery. So, if you have a hiatal hernia, and for example, you notice that you're getting really severe chest pain that's unremitting, or you just feel much more off than usual, those things may be signs that something is happening. And usually
Mhm.
that would be something that I would recommend going to the hospital for if you need to.
Okay, so that's a good piece of information because most hiatal hernias are asymptomatic, right? So many people don't even know that they have a hiatal hernia. And so these are sort of just some of the statistics. In the United States, approximately 20% of the population actually has a hiatal hernia. And some of the reasons why people get it is just as people get older. They can have weakening like of any muscle. And Dr. Zarnaga was, talking about that hiatus. It's basically this defect in the diaphragm, and the diaphragm is really basically just a big muscle, and things can become weaker, and that's just with age that there's a higher chance of people having a hiatal hernia. Um, Obesity, people just having some more weight in the abdominal cavity. Dr. Katz, could you just even give an understanding of why that would be? So why would someone being heavier potentially, why would that, encourage the development, the formation of a hiatal hernia? What's happening there?
In general, the thought processes are um, increased pressure in the abdomen, the genesis of obesity when one overeats or eats fast or eats a lot, the stomach distends. The increased distension in the stomach can put pressure on the sphincter muscle at the lower end of the esophagus to open when it's not supposed to, for multiple reasons that we don't completely understand. And then how the presence of intra-abdominal fat and the resultant inflammation that comes from intra-abdominal fat can perhaps affect the sphincter remains to be worked out.
Mm.
But those are the principal reasons.
Okay, so I guess along the same sort of thinking, any condition that increases pressure in the belly, like weightlifting and how individuals can really strain to increase their intra-abdominal pressure when they do a lot of weightlifting, or pregnancy, all of these things, along the same line could potentially increase the chance of having a hiatal hernia. So, Dr. Zarnaga, just going back to you now and talking about different types of hiatal hernias. Are all hiatal hernias the same? When we say hiatal hernia, and maybe some people have heard about this para-esophageal hiatal hernia versus just a regular hiatal hernia. But could you just explain sort of the difference and how the audience should think about this?
Yeah, I mean, I think most people will end up typically having sliding hernias, and those are the people that usually have heartburn and regurgitation as their main symptoms. And most of that is because the esophagus and the stomach that are connected at the G junction will kind of slide in and out of your chest all the time. And a lot of people, for example, will have more symptoms maybe when they lean over or when they're doing weightlifting or some type of exercise, just because of that movement of that stomach in and out. The paraesophageals can give you similar symptoms of heartburn and regurgitation, but they more commonly present with having people having difficulty swallowing, or they can be just, have no symptoms whatsoever. And that usually entails actually not the esophagus moving, but basically the stomach or other organs sliding next to the esophagus. So there's actually, several types of paraesophageal hernias. The simplest being, the stomach sliding next to the esophagus, but there are other ones where other organs, including the colon and everything else, is slipped into the chest, and you can usually see this on imaging, including stuff like CT scans. So those are kind of good tests to figure that out. Again, they're very uncommon, and a lot of people present without symptoms, but some people can present with problems swallowing. They get full really quickly. Some people will get short of breath because of these bigger hernias. But that's sort of the distinguishing feature between those two.
Okay, so this one on the left is the regular sliding hiatal hernia, and so the sliding is basically this piece of the stomach that's going through this opening. And then this para just means next to it. Is that what you meant? Like that the stomach is
That
kind of coming up next to on the side of the esophagus. Okay, but all of these are hiatal hernias.
that is correct. They're all hiatal hernias, just sometimes present with different symptoms and so on and so forth.
Okay, understood. Okay, so how do we evaluate hiatal hernias? Well, as we mentioned, many people have absolutely no symptoms. With our patient, regurgitation, heartburn, sometimes even chest discomfort and fullness can be the symptoms they have. And then there could be some sort of red flag symptoms that are happening, things that really require evaluation, vomiting, anemia or low iron, and even weight loss. So there are different tests that we might use to evaluate hiatal hernia. We've gone through the upper endoscopy and showed what that looks like. And then there's a barium esophagram and then a CT scan of the chest. So this is an image of a barium esophagram. And, Dr. Sampath, as an interventional endoscopist, I'm sure you order a lot of barium esophograms on patients that you're evaluating hiatal hernias for. So could you talk to us about why do we do this? What does this test do? How does it add to our understanding of the patient? And what does the patient actually experience when they have a barium esophagram?
Right. Thank you for the question. So when you're doing an esophagram, they're coming into their radiology suite. They're usually upright. They're swallowing a liquid, which you can see on fluoroscopy or X-ray, and then you can see a nice roadmap of the esophagus, the lower esophageal sphincter, or at least that tightening, generally speaking, and then the stomach. Now, when you see this little bulge above the diaphragm, or what I should say, a little isolated, if you will, it's suggesting that there's a hiatal hernia here. And that helps us to understand not just the anatomy, but how the anatomy could be correlating with the symptoms. Okay. And it can also, depending on the symptoms, help explain if there's a more urgent hiatal hernia, something that really should be fixed more promptly. And that can help you to counsel patients going forward. So that's the exam itself, the imaging, and the different types of anatomical understandings we can have, and how that can help guide management going forward.
Mhm. And so, Dr. Katz, do most patients who have symptoms like our gentleman that presented today, and when you said, do you usually get a esophagram in the evaluation of a patient? Is that common part of your workup?
Um, this type of patient, I would quite frequently get a barium study, in part because of the concern for the anemia and wanting to understand the structure of the hernia as much as possible, um, uh, both for Dr. Zorniger's purposes and for Dr. Sampath's in terms of planning therapy.
Okay.
A large majority of patients don't need one, but this type of person, because of the features we've already mentioned, would get one.
Okay, excellent. And Dr. Zorniger, just in terms of like the different hiatal hernias that you spoke about, does an esophagram help you differentiate sliding versus that para-hiatal hernia that you were talking about? Are you able to see the difference on this, or are you not able to see those features on this?
Most of the time you can for a lot of the different hernias. Sometimes if you have other organs that are in the chest, the esophagram may not be good enough, but those are very rare. But if there's any suspicion of those things, sometimes we'll get also a CT scan to help. further differentiate them, if
Okay,
that makes
so
sense.
it's possible that it might be good enough, but our team might actually even require a CT scan based upon what we see on this study. Okay, excellent. So there are, when we're thinking about the patient and what we need to do, we've set, recognize that there's a hernia. And Dr. Zorniger and the rest of the, our panel spoke about the fact that the stomach is moving up into the chest. And basically, really, what we're trying to do are several things. So, Dr. Zorniger, just talk about these first two things, reducing the hernia, closing, tightening. I mean, are both of these things important? So as a surgeon, and even as an interventional endoscopist, Dr. Sampath, when you see the patient that and their exams that we've seen, do you have to do both of these things? What does it entail if we need to start fixing the problem, this mechanical, I would even say sort of like the patient has like a plumbing problem, right? Do you have to do both of these things, to help this patient?
So I can comment first. Essentially, you're looking at the anatomy, you're looking at the size of a hiatal hernia, you're looking at the width of the hiatus. When you're looking in that candy cane maneuver that Dr. Schultz-Sussman showed before. So you're getting an assessment of that anti-reflux barrier. And there's so much internal information that we're all processing as physicians when we do an endoscopy. And that really helps us to understand, in some ways, the mildness of the hiatal hernia, the moderateness, or the severity of that hiatal hernia. If it's a smaller type hernia, there may be some endoscopic options, but that also involves that suggests that the valve, the diaphragmatic area is not too wide. But if we don't recognize that correctly, then we could do the wrong intervention for the wrong patient. So understanding those components of that anti-reflux barrier, which inherently includes evaluating the hiatal hernia, that can help myself and my colleagues determine whether I can help the patient or whether it'd be best off either in a combination approach or primarily with Dr. Zarniger.
Mm. Okay, so it's really a complicated kind of conversation that we're all having, right? Who is the right patient? What are we going to actually do? What is actually necessary to be done? And so there are multiple different types of procedures that could be done. But I'm going to actually turn for a minute to Dr. Katz. So Dr. Katz, this patient where they are right now, before we actually get into the different types of procedures, are you thinking right now, based upon this patient's presentation, that you would actually be, bringing in Dr. Sampath or Dr. Zarniger into the conversation, that we actually need to move forward with doing something, to this valve, to the stomach at this point?
I would complete the workup with one more test,
Hmm.
but the answer is yes.
Okay.
I would be thinking about fixing this hernia for some of the reasons that I brought up at the beginning.
Okay, so perfect. So there are several different types of anti-reflux procedures. We're going to go through these in much greater depth, but a big group is called a fundoplication. Another is an endoscopic type of technology. We'll go through that. And another is a magnetic sphincter augmentation. These are three different ways to do this, and we'll go through those. But Dr. Katz was alluding to the fact that maybe the workup is not done. So, what other tests, Philip, do you think is necessary actually for us to really understand this patient before we send them on for any type of repair?
So it should be clear to the audience that we're talking about a multidisciplinary approach here, and that we're talking to each other, that no single specialist is often sufficient to figure out what to do. And part of the evaluation should always include esophageal function or esophageal movement or esophageal motility, as we would call it. And that's done by doing esophageal manometry, which is a test that is illustrated in cartoon fashion here, which is designed to determine how effective esophageal motility is. That is contractions of the esophageal body itself and movement when people swallow. This is a pictorial illustration of that. At the top is what happens when the upper sphincter opens. The movement noted going down of a contraction and the opening of the lower esophageal sphincter at the bottom. All of these contractions are normal. The sphincter opening is there. This picture actually does show a potential subtle, what we call a double high pressure zone, uh, potentially indicative of a hernia. And this would be the ideal manometric findings for any kind of intervention involving either endoscopy or surgery to repair this hernia. There are a fair number of swallows in here that are just random and are not included in the evaluation, but this looks like a very normal uh, intervention.
Okay, great. So, so this test is done with a patient that's awake, and that initial cartoon showed that we're placing a tube down the nose. And basically, the reason for that is just as Dr. Katz had shown, we actually want to see the patient swallow. So, most patients, find this test they can get through it. It's not as comfortable as obviously as some endoscopies where you're sedated. But Dr. Katz, could you also just talk to, you said that a lot of the swallows looked like they were really good swallows. So this is showing two different swallows side by side. Can you just briefly walk the audience through what we're seeing here as the difference?
Yeah. So this, to remind again the audience, this is a test that takes 20 minutes. When it's done well, with a comfortable patient who is motivated to get the most information possible. On the left is a normal swallow. The upper sphincter opens, the contraction progresses in an orderly fashion down the esophagus. The dark area there is a good squeeze force, and the sphincter reasonably opens well compared to on the right, where the upper sphincter opens. The upper esophagus is normal, and then as it moves into the smooth muscle or the involuntary portion, there is a decrement in squeeze force. This is abnormal. This is an ineffective contraction, and that would affect what Dr. Zorniger and or Dr. Sampath would be contemplating in choosing their procedure.
Okay. So this test is about understanding how well the esophagus is moving, the strength of the esophagus. And I think that, you obviously Dr. Katz did a wonderful job in explaining to us when it might not look perfect. Now, Dr. Sampath, one of the tests that we might want is just really to prove if the person does or does not have reflux. So can you just briefly talk about this test that we're seeing here? What is this? This is called a Bravo or a pH test, and what are we looking at here?
Absolutely. So, what we do is we do an endoscopy. It's usually under anesthesia without necessarily needing a breathing tube or anything of a deep sedation in that sense. We then do the endoscopy. We take a look at that anti-reflux barrier, and just as what was described prior. And then ultimately, we back our way up to the distal mid-esophagus, and we place this probe. This probe is a wireless probe. It's able to transmit data to this recorder, which is what you're seeing with that gray box. That gray box just hangs out on your belt buckle, similar to a Walkman or an iPod or whatever it may be. And ultimately, you're able to 24/7 over 48, but more likely 96 hours, transmit data, which is measuring acid exposure. And what we're able to do is we can get that data. We can understand how that data correlates with symptoms because we keep a diary, which is of the utmost importance. And we're able to match symptoms, acid exposure, and then also behavioral stuff like lying flat. And ultimately, it gives us a very nuanced understanding of a patient's acid exposure, reflux disease, and that can really help guide the diagnosis and the upcoming management. So it's a really crux of the next steps in terms of managing a hiatal hernia, in terms of understanding that disease process, in addition to a proper foregut exam.
Okay, so they go home with this little pill sort of attached to them, and between the manometry test that Dr. Katz was talking about, helping us to understand how well the esophagus moves, and this test helping us understand how much acid is coming up, it really gives us a sense of whether or not the symptoms are related to acid coming up. So now we're going to move to understanding what are we going to do. So we do the testing. We see the patient is actually refluxing. And now we have to decide what are we going to offer this patient. So, I'm going to ask all of you to sort of help me with this conversation because we're looking at four different things here. These two fundoplication tests, this thing in the middle, this magnetic sphincter augmentation test. So what are these different tests about, and how does one even decide in our multidisciplinary conferences what we're going to offer the patient? So, Dr. Zarno, could you just start the conversation for us about how do you decide what surgery to even potentially offer a patient?
Yeah, I mean, I think when you finally kind of decide the surgical route is the way to go, and that's usually patients that have been selected by the multidisciplinary groups that are good candidates, and also people that usually are kind of progressing to that stage because of their management's medically have not been ideal. Then surgery becomes a good option. Again, we do a lot of these minimally invasively now, so people go home early, but the type of wrap is dictated by how well your motor function. And I think Dr. Katz talks about very nicely about manometries. And when you look at magnetic sphincter augmentation, which is usually like a magnetic bracelet you place around the esophagus to kind of tighten and relax as you eat, usually if you don't have enough pressure your esophagus generates when you're swallowing, that would not be a good approach. And I think we usually would talk people away from that approach if they don't have the right motor function, and which is why it's so important to get this preoperative testing done. As far as the wrap types, the classic is always a 360 wrap, which was the image all the way to the left. That's done called a Nissen. It's a full wrap around the esophagus. That actually historically has been the wrap that's being done the most. And there's a lot of data on it. The toupee, which is the 270 wrap, is kind of what we call a partial wrap. It's not a 360, it's a 270. It works sort of the same way, and actually a lot of the data is now showing that the outcomes of all the different procedures are very similar as far as anti-reflux barriers. But a lot of these different features are to mitigate side effects that people would be worried about, and that's what we're trying kind of modulate the wraps based on the patient and their other symptoms so we can make sure they get the right procedure done.
Dr. Zonager, so I know you're talking about like 360, which means like a full circle, 270. What are you wrapping? What
Yeah,
exactly is what is the wrap?
yeah. Yeah, that's a good question. Yeah, so what we actually do is we take a small piece of the stomach, a very negative amount, maybe like 2 to 3% of the stomach, and wrap it around the esophagus to like make the valve more robust. Most people, when they have reflux, it's because that valve is not working well. So the wrap kind of helps support it, so it's a little tighter, and so you don't have those reflux symptoms. And a lot of patients that have these wraps will have if they have heartburn or regurgitation, those respond in over 95 to 98% of cases to the wrap, basically. But we
Hmm.
take a small part of the stomach.
Okay, and then you're able to when during surgery, just so our audience understands, this toupee is the same thing, a small piece of the stomach, but you're just able to physically see that you're not making it as tight. Is that what is happening?
That's correct. So you'll basically know it's all visual. A lot of this is done based on experience, and a lot of the foregut surgeons with good experience will know how to tighten the wrap in a certain way. But basically, you wrap it so you see some esophagus through it. So anatomically, you'll see exactly where you need to be. and it has definitely less side effects than the Nissen. So even though I used to be a big Nissen person a long time ago, we've moved over to the toupees more commonly, but we sometimes still do Nissens on select patients based on what we're doing it for.
Mhm. So at the time of surgery, you're able to try to make sure it's not too tight, like that this is still open, that the esophagus is still open.
Exactly.
Okay.
And yeah, so you can see it visually, and we use some other technology enteropathy to look at it, and we also assess it endoscopically to make sure it looks perfect. But there's a couple different tricks that we have that can help us make sure that it's not too tight, because a lot of patients will worry about having problems swallowing and so on and so forth, but it happens very uncommonly because we follow our patients quite thoroughly moving forward, and it's pretty rare.
Okay. And so
So,
briefly, what,
so,
oh,
so
Dr. Katz.
Dr. Zoniger, you're being quite modest since you were the first person to describe using a device to help during surgery to actually make certain that the fundoplication and the hiatal hernia repair are optimal. That's something that happens at Cornell quite regularly when you operate on people. Um, so it's an advance that may help to actually uh, make the surgery more precise.
Yeah. And I appreciate you bring that up, mentioning that, Dr. Katz. And Dr. Zoniger, if you were doing a fundoplication just for patients to understand what is like the downtime after this type of surgery for patients, just that let's say they go for that, what is the classic in someone that just does, really what, gets through it. What is it the experience afterwards? Like how long are they not able to go to work and things like that?
So I'm pretty aggressive on getting them pretty active pretty quickly. So 80% of our patients actually go home the same day.
Hmm.
The re-ops and the more, if people aren't tolerating enough of their diet, they may stay overnight, or if they just don't want to go home. But most people will end up going home the same night. I actually don't give them a lot of breaks. So I usually like them walking at least a mile a day after surgery. We start them on a kind of a specific diet that they progress over the next couple of weeks. I've had people go back to work the next day, which is a little extreme. But I've had people go back the same week and the next week. But I think the faster you get back to your normal life, the faster your recovery. So I don't give you a lot of downtime. I don't like you doing any heavy lifting or core exercises. But as far as walking and going back to working and stuff, I'm actually pretty aggressive about getting them there as soon as possible.
Okay. And Dr. Katz, could you just describe to us on the right is this other technique, this magnetic sphincter augmentation. So what exactly is that? What's happening there with that?
This procedure was developed to attempt to standardize the procedure to avoid some of the issues that Dr. Zarniger brought up with creating a fundoplication. It's a ringed magnet. It's sized by RASA and is pretty relatively simple to size. It's tied, so these are titanium beads that are magnetized. It's wrapped below the diaphragm, and it's meant to allow for control of reflux with perhaps fewer side effects in terms of ability to belch and vomit, and has an advantage that occasionally I suspect Dr. Zarniger likes to bring to patients, but is worth talking about that it can be removed.
Okay. So these are magnetic beads that are placed around the esophagus and creating that another barrier, like what Dr. Zarnik was talking about. Whereas in the fundoplications, you're using the stomach, that magnetic beaded bracelet is acting like that new barrier.
That is correct. And Dr.
And
Zarniger is going to tell you to
okay,
eat, eat, and eat, so that
okay.
little thing will open quickly.
Yeah. And so, Dr. Zarniger, can this be done? So that is creating the wrap piece. In this patient, we were talking about hiatal hernias. So could you just talk to us about, can you do also a hiatal hernia repair with this?
Yeah, so yeah, you definitely do a hiatal hernia repair with any of these procedures. So I think when we do these surgical approaches, I think the most important part of the procedure really is, fixing the hiatal hernia. And a hiatal hernia, a lot of people, my patients say, "Hey, do you just cut out the hernia?" And it's really not cutting out the hernia. The hernia is the hole you just have, and we actually try and close the hole after we bring the stomach to where it's supposed to be. But I think that's actually the most vital part of the procedure. The wrap type is to kind of hold everything in place and also augment the hiatal hernia closure. So you can do typically with any of these procedures, we will always fix a hiatal hernia. And if you don't, then you may have higher rates of failure. So most expert surgeons will recommend doing both at the same time.
Okay, so that's an important piece for our audience to understand that we're actually, tightening this, but we're repairing the hiatal hernia as well. And these are, both very important parts, of this procedure to get the best success story for our patients. So, Dr. Sampath, as an interventional endoscopist, this is another technique that patients, might want to know about, which is an endoscopic alternative to actually doing repair, called a TIF. Could you talk to us about what this is?
Yeah, essentially, we're putting our scope through a certain device, which is a little bit like an overtube. It stretches things out to 60 French or so, and people may not understand what that means, but it's roughly a little bit of a larger width. So it's a little bit of a bulkier device. We get it through, and we do a candy cane maneuver, which is what you're seeing there. And we're able to grab tissue in the stomach and then wrap it around itself to create that pressure zone or to help minimize future reflux events. Now, can be a effective procedure, but you have to make sure you have the right anatomy. And that what that means is that you can't have a very large hiatal hernia. The hiatal hernia has to be 2 centimeters or smaller. On top of that, things that can be under-recognized is the width of that diaphragm. If it is too wide, then simply just doing the wrap by itself won't necessarily be a durable intervention. So it's important to do that good foregut exam, assess that anti-reflux barrier, as I mentioned before, and ultimately pick the right procedure for the right patient. When you look at this picture here, you can see how we can grab the tissue, wrap it, and then place these plastic appearing fasteners that helps create what we call gastroesophageal plications, or these little mini tightenings between the stomach and the esophagus. That's what keeps the wrap in place to, like I said, improve that pressure zone to minimize, in some ways, the plumbing issue, right? Minimize stomach acid from coming up the esophagus. And it is a purely endoscopic procedure. You can do it with the right anatomy as a primary intervention non-surgically. However, a lot of people do have hiatal hernias or do have a widened diaphragm. And so for those patients, you would really need to combine this with some sort of a surgical-based intervention to really make sure we have an effective outcome, but more importantly, a durable outcome when it comes to an intervention.
Okay, so in this patient, could we just do this TIF procedure in this patient? It sounds to me like, based upon what you're saying, that you would want to, as Dr. Zarnik was talking about, repair the hiatal hernia and also do this tightening. So is that possible? Dr. Zarnik, could you just talk about that for a moment, like doing this endoscopic procedure and then also repairing the hiatal hernia?
Yeah, and we have done this at Cornell now pretty routinely now, where my team and the GI specialist teams work together and do these combined procedures. And I have to emphasize that a lot of times when we do these things, it's not like one wrap always is better than the other wrap in preventing reflux. It's mostly to reduce side effects. Some people are concerned about bloating, which is more common side effects with, for example, Nissens. So a lot of these other procedures come around to avoid some of the side effects that gastroenterologists and patients have to deal with to kind of, hopefully avoid the side effects that can occur from these procedures. So yeah, we've done these before. I think it's really nice. It's very elegant to do it. And I think the way we do it is we go in robotically and fix the hiatal hernia. And then the advanced GI teams or the GI teams come in and then do the transoral fundoplication. Patients, again, typically go home the same day, and they kind of resume their normal life. And I think that's really important.
Great. So lots of different options, and it really sounds like you need to really talk about this patient. It's not just simple reflux. It's reflux. What are those reflux symptoms like? What does the anatomy look like? Whether or not there's a hiatal hernia or not, and then a real conversation on what we could offer. So now, bring it back to the patient. So, Dr. Katz, do we need to fix our patient's hiatal hernia? So, could you just run through kind of, these things about how we, in our group, which we meet all the time, obviously, sitting together, just talking at great length about these patients. But if we bring it back to our patient from the beginning, do we need to fix, do we need to offer this patient more? Would you consider offering this patient more, and why?
So this patient has a little add-on because of the anemia. But in general, uh, I think I do talk with every patient with substantial hernias, particularly with regurgitation, about the option for a surgical intervention or the combination of surgery and a transoral incisionless fundoplication. People who are still symptomatic despite medicine. This is a patient who worked very hard to get to ideal body weight, took medication and was not happy. That would be an ideal candidate for a repair. Um, Several studies have shown that repairing hiatal hernias can result in a response of the anemia. That way, no iron is required. And ultimately, a patient preference not to take medicine are the indications. This patient, I would kind of push towards getting a repair, in part because of the anemia. We might spend a little more time at another place talking more detailed about how much medicine, et cetera. But this is an ideal candidate for a repair and a non-medical intervention.
Yeah, yeah, I agree. I mean, when I think about this patient, what they've really done, to really try to help themselves, it's obvious that they just need more because it really sounds like they've really done everything. And based upon the anatomy that we've seen, I think that they do. So, patient goes for surgery. Dr. Zarnagar, what surgery did we ultimately choose to do on this patient?
We ultimately ended up doing a hiatal hernia repair with a two-pay fundoplication.
Okay, great. And so, why, just to like wrap it all up for us, patient no longer having symptoms after this surgery. They actually are off of anti-reflux medications, which is really obviously another beyond just having no symptoms. Being able to get them now off of medications is another real benefit, which we didn't really spend that much time on, but certainly some patients just have these surgeries done because they just don't want to be on medicines anymore. And then, we were right that those erosions that Dr. Katz had pointed out at the beginning were likely a source for slow oozing and slow bleeding. And several months after surgery, his iron and his blood levels had improved. And I would say what is probably the most important thing is that we have a happy patient. And that's obviously what all of us want, in the end, is to just have that. And, the patient really didn't have symptoms afterwards, able to eat, uh, able to swallow, and really didn't feel like they, several months later didn't remember they actually had surgery. It was kind of just they were back to where they had been, many years before. So I think that this is truly a success in the management of a patient like this. So I would love to, thank our entire panel tonight. I think what we saw tonight was sort of the full compilation of what we do with these patients, who they are, why we do what we do, the different ways that we would surgically actually manage them. And of course, not every single patient does perfectly. We try our best to actually do the best workup at the beginning because that's how when you select the patient and you do that careful evaluation, as we spoke about, you can get great outcomes. So I want to take the opportunity to thank my expert panel for all that they shared tonight. Dr. Katz, Dr. Zarniger, Dr. Sampath, it's just an absolute honor to have an opportunity to work with you day in, day out in managing these patients. And I'd also like to thank the audience for joining us tonight. And I would like to just give you an opportunity to know our next virtual webinar is going to be on a condition called eosinophilic esophagitis, diet, drug, and dilation. It's going to be on July 8th from 7:30 to 8:30 p.m. We have another expert panel and moderator that will be there. We look forward to you joining us then. For that, I'd like to bid you a good evening and thank you so much for joining us. Have a good night.
Good night, everybody.